Coming to orbit, orbit has four walls: roof, floor, medial and lateral wall. The medial walls are parallel, whereas the lateral walls make an angle 90 degrees. As you can see here, this is the 90-degree angle that we have, two lateral walls, and the medial walls are parallel. So the angle between the two lateral walls are 90 degrees, whereas the angle between the medial and the lateral wall is 45 degrees, and the optic nerve goes in between. So the optic nerve cuts the or the orbit into 28 degrees here and 20 degrees there. So this is the basic anatomy which you should know. The base of the orbit is the orbital margin and the apex is the orbital foramen. So the eye is placed inside the orbit. The function of the orbit is to prevent damage to the eyeball. So volume of orbit is 30 cc, whereas the eyeball itself is 6 cc. So basically for the 6 cc eyeball to be protected, you need for 30 cc of volume of the orbit. So as you can see here, all these bones, frontal bone, ethmoid bone, lacrimal bone, all these things you can see here, and maxilla, zygoma, zygomatic bone, zygomatic-temporal, sphenoid here, supraorbital foramen, all these things you can see in this picture. So coming to roof of the orbit, it's formed by lesser wing of sphenoid and orbital plate of the frontal bone. Middle wall is formed by four bones: maxillary, lacrimal, ethmoidal and sphenoidal. Floor is formed by zygomatic, maxillary and palatine. Lateral is formed by greater wing of sphenoid and zygomatic. So when I was studying for entrance exam, there was a mnemonic which I'll tell you now. The medial wall is formed by USMLE, except the U, SMLE. So sphenoid, maxillary, lacrimal, ethmoid. Okay, and the floor is formed by PAMA-Z. So palatine, maxilla, zygomatic, PAMA-Z. Whereas the lateral wall is formed by ZyGS, zygomatic and GS, greater wing of sphenoid. And the roof is formed by, since greater wing of sphenoid we told you, its roof is formed by lesser wing of sphenoid and the frontal bone, obviously frontal bone is here. So that's how I remembered, and it was very useful till date, that mnemonic. So USMLE, U, skip that, SMLE, PAMA-Z, ZyGS, lesser wing of sphenoid and frontal bone. That's it. So floor is the most frequently fractured wall of orbit in trauma. That's why it's called blowout fracture. Middle wall is weakest wall, lateral wall is the strongest wall. Though I said middle wall is the weakest wall, but the fracture is more common inferiorly. The reason being, the medial wall has ethmoidal sinus, which is like a honeycomb appearance, which prevents, like acts as a cushion, whereas the inferior wall, the maxillary sinus is a hollow space where one small breakage it opens up. It's like a vacuum here. So suddenly if there is breakage, there will be opening up of this inferior wall. So that's what is called blowout fracture. And strongest wall is lateral wall. We'll talk about blowout fracture in detail. Optic canal, optic foramen. Okay, so basically it's formed by lesser and greater wing of sphenoid. It lies between the roof and the medial wall. Okay, its vertical oval length is 6 to 11 mm, diameter is 4 to 6 mm. All these things are important, and then it transmits two important structures. One is optic nerve and the ophthalmic artery. The best view for imaging optic canal is Rees view. So coming to this optic canal, if there is, or this is called orbital apex syndrome. So if there is any affliction of the optic foramen, what happens is the eyesight will be lost. That is the main thing which you should know. So this is very important. This is superior orbital fissure, where the annulus of Zinn divides the superior orbital fissure into three parts. The first part, which is above the annulus of Zinn, which is formed by LFT, lacrimal, frontal and trochlear. This is an age-old mnemonic which you should know. And then superior branch of ophthalmic vein will be there. In the annulus of Zinn, okay, inside the annulus of Zinn, there are two divisions of the oculomotor nerve, abducent nerve, and then nasociliary nerve. The last part of the ophthalmic nerve, which is LFN, lacrimal, frontal and nasociliary, that nasociliary comes here. Then you will have third nerve and then sixth nerve. Then the inferior, below the annulus of Zinn is inferior ophthalmic vein. This is very important, which you should know. But here the problem is, if the superior orbital fissure syndrome happens, it doesn't affect the optic nerve. only these structures will be involved, which is third nerve, then the fourth nerve, and then the fifth nerve, and the fifth nerve, that is particularly ophthalmic branch, and then sixth nerve. These are 3, 4, 5, 6. In fifth also, it will be only the ophthalmic division. So that's very important to differentiate. And optic nerve is not involved. That is, the second cranial nerve is not involved in superior orbital fissure, and the maxillary division of the ophthalmic nerve, maxillary division of the trigeminal nerve is also not involved. So as I have already told you, the structures passing through superior orbital fissure, above the annulus of Zinn, it's a LFT, lacrimal frontal and trochlear nerve, like liver function test, and then superior ophthalmic vein. Whereas through the annulus of Zinn, it's two divisions of the oculomotor nerve, abductor nerve, and isociliary nerve. That LFN is branches of ophthalmic branch of trigeminal nerve. So that LFN N comes here in the through the annulus of Zinn, and below the annulus of Zinn is inferior ophthalmic vein. Space of the orbit, which is very important, subperiosteal, which is between the orbital wall and the periorbita. As you can see in this superb diagram, where the orbital space is between the orbital wall and the periorbita. Extraconal is the space between the periorbita and the extraocular muscle, whereas the intraconal space is the parts that is enclosed within the extraocular muscles. The structure within the extraocular muscles is the intraconal space. The structure which is outside the intraconal space is the extraconal space, and the structures outside that is the subperiosteal space. Coming to cavernous sinus, it's a venous sinus in the brain. There are two sinuses located in either side of the optic chiasma. Each sinus have valvulus communication with the facial veins. So infection to the dangerous area of the face has a potential to reach cavernous sinus. So if there is any infection here, or nose picking or something, that infection can directly go into the cavernous sinus, which is very, very dangerous. Because there is a communication between the two parts of the cavernous sinus. What happens is whatever affliction happens, that happens bilaterally. So this is a very good diagram which you should know. This is cavernous sinus. It's between the sella turcica. As you can see, the sella turcica, Turkish saddle, which has the pituitary gland, and both sides you have this cavernous sinus. So the cavernous sinus, inside the cavernous sinus, main structures are internal carotid artery and the sixth nerve, that is inside the cavernous sinus. So internal carotid artery it's surrounded by the sympathetic plexus, whereas outside the wall of the cavernous sinus is the third, fourth, fifth nerve, ophthalmic and maxillary division, that is there on the outside. This is very important because the first nerve to get affected in cavernous sinus thrombosis or cavernous sinus fistula is sixth nerve, and there is affliction of the sympathetic plexus also. So third, fourth, fifth, 1 and 2, that is ophthalmic and maxillary division is affected here, whereas in superior orbital fissure I told you that the maxillary division is not affected. So those are the differences, and second nerve is never affected here in cavernous sinus thrombosis. So structures in the cavernous sinus. Within the cavernous sinus there is the internal carotid artery with surrounding sympathetic plexus and sixth cranial nerve. In the lateral wall of the sinus lies the third nerve, fourth nerve, fifth nerve, ophthalmic and maxillary branch, and thus involvement of cavernous sinus presents with involvement of third nerve, fourth nerve, fifth nerve, ophthalmic and maxillary branches of fifth nerve and sixth nerve. And there will be proptosis due to engorgement of orbital veins which communicate with the cavernous sinus. There will be proptosis, and conjunctival congestion, chemosis, all these things will be there. So second nerve is not affected, and maxillary nerve is affected here, whereas in superior orbital fissure that's not affected. And first nerve to get affected is sixth nerve, whereas there in superior orbital fissure there is no such rule such as sixth nerve should get affected. Here the other part is the sympathetic plexus is affected, so Horner syndrome possibility is there in cavernous sinus.